Hello everyone and welcome back to another episode of OSCE Talk. Today we're going to be going through pediatric hip disorders and focusing on the pediatric limp. I'm just going to take us very quickly on an easy way to remember some of the most common things to rule out in terms of pediatric limp, some of the more benign causes, and then go into some of the more severe causes, including malignancy. So just to say that children often sort of struggle to locate actually the pain in the hip. They can often present with sort of back pain, knee pain, or just non-specific hip or groin pain. So it's important always in MSK to examine the joint above and below, especially in children. So we're going to focus on a few key diagnoses that will include things like DDH, which is developmental dysplasia of the hip, Perthes Disease or avascular necrosis of the femoral head, slipped capital femoral epiphysis in slightly older patients, Transient Synovitis, which would normally be kind of a diagnosis of exclusion after a viral illness. But then we also have to think about those very severe conditions such as septic arthritis, where there's infection and inflammation inside the actual joint, which could then spread to the bone and cause osteomyelitis. And then down to things like malignancy, and that will be things like osteosarcoma in patients, which again is rare but is important to consider. So really the easiest way to remember these is just to go through the age ranges. So for patients who are 0 to 4, very young patients, that will be developmental dysplasia of the hip or DDH. That's something that's screened for in the newborn screening. That'll usually be done the first few days of life. And then usually after about 6 to 8 weeks, they might get further screening. So that should be picked up quite young. Things that will then be sort of 4 to 10 years old, that'll be things like Perthes Disease, which again is kind of that progressive, slow, worsening limp. And then transient synovitis, like I covered, which would be one of your diagnoses of exclusion. And then slightly older children, sort of 10 to 16, will be slipped cap femoral epiphysis. And then in and amongst that, you need to be thinking, could this be septic arthritis or could this be a malignancy? Peter's now just going to take you quickly through what developmental dysplasia of the hip will look like.
Yep, so developmental dysplasia of the hip, or DDH, is a condition where the hip joint does not develop normally. Instead of the femoral head sitting securely within the acetabulum, the joint may be unstable, partially displaced, or even dislocated. And it's a common hip abnormality in newborns. Important risk factors are being a breech delivery or a family history of DDH. All infants should undergo screening in their newborn baby examination using the Barlow and Ortolani manoeuvres. This helps to identify if the hips can dislocate or relocate. So most cases are detected early through the newborn screening, but milder dysplasia can occasionally be missed and present later in childhood. In those cases, children may develop reduced hip abduction, leg length discrepancy, or an abnormal gait. Investigations depend on the child's age, so if infants are under about 4 to 6 months, we usually use ultrasound, but in older infants, we might do an AP pelvic x-ray. Management can also depend on age, so in babies under 6 months, we'll use what's called a Pavlik harness, and this helps to hold the hips in flexion and abduction to encourage normal joint development. However, if this is unsuccessful or the condition is diagnosed later in life, we may need to use surgical correction. And Matthew's just going to talk you through Perthes disease now.
So Perthes disease, also known as avascular necrosis of the femoral head, will typically be sort of boys aged 4 to 10. These patients can have limp with hip or groin pain, that reduced range of motion, and the most important one to remember then for Perthes disease is internal rotation and abduction is lost. They then can also present with knee pain as they try and compensate. They might get muscle spasm and tight muscles, and they may also have leg length discrepancy if this continues to go on. You'll then need to work them up with x-rays, so that'll be AP pelvis x-ray and then also the frog leg laterals. You might see flattening of the femoral head indicating breakdown because of the avascular necrosis, and then you might also see the crescent sign in later disease. So as with many things in medicine, there's going to be the main options of conservative or surgical management. Most of these patients will be managed conservatively. They'll get physio, rehabilitation, non-steroidal medication and observation, and possibly followed up by the orthopedic team. If they continue to have significant mobility that's debilitating and limiting their daily lives, then they may get reviewed by the orthopedic team and possible surgical management. It also may be based off imaging. Complications of this longer term for the patient might include osteoarthritis of the hip, leg length discrepancy, joint stiffness and muscle tightness as well.
So I'm just going to talk through a slipped capital femoral epiphysis. This will sometimes be referred to as a SUFE, and it is the most common hip disorder in adolescents. So in this condition, the head of the femur slips and moves out of line with the growth plate. This most commonly affects adolescent boys, particularly those who are overweight. Clinically, children will present with hip, groin or knee pain along with a limp. They might have external rotation of the affected leg, particularly when the hip is flexed. Range of motion is typically reduced, especially internal rotation. The important fact to remember, and often comes up in MCQs, is that the diagnosis is made with an AP pelvic and a frog leg lateral x-ray. And importantly, this is often treated surgically, and screws are often used to try and stabilise the growth plate to the head of the femur.
So as I previously mentioned, one of the very important conditions to exclude would be septic arthritis, and this is something that could be confused with transient synovitis if you don't carry out a proper history and exam. So transient synovitis can come about really at any age. Age is really 4 to 10, and that's often after a recent viral illness, such as just a simple upper respiratory tract infection or gastroinfection. Again, presenting with sort of limp, hip pain, a bit of tenderness, and they may also sort of hold their hip in sort of abducted, externally rotated flexion. But the main thing to rule out here is going to be septic arthritis, and that's going to be a hot, red, swollen joint. And one of the easiest ways to go through that is Kocher's criteria. So some of the Kocher's criteria would be fever, unable to weight bear, within elevated inflammatory markers, so elevated white cells and CRP. These sort of patients will also likely be systemically unwell. They may have temperatures and they may be quite lethargic. It's important that you think about sort of the blood tests that are needed alongside x-ray, and then also ultrasound of the joint, with an aspiration being one of the ways in which you could diagnose this, with a sample of the fluid being sent off for microscopy and culture. Again, transient synovitis is more of the diagnosis of exclusion in these patients. It should be self-limiting and it should resolve itself within a week to 2 weeks. Mostly these patients will just rest, get NSAIDs, paracetamol, simple analgesia, and they should recover back to normal. Obviously, patients with persisting, ongoing pain in the hip or joints, which are red and swollen, they've got systemic temperatures, and they look generally unwell, they should be sending them to Paediatric Emergency Department for further workup. One of the final things I'm going to go through is osteosarcoma, and again, that's malignancy of the bone in the pediatric patient. So osteosarcoma sort of occur more commonly in older children and teenagers, and they're very rarely seen in children under 5. Common sites for osteosarcoma can be places around the femur, but it can occur in the shoulder joint and even in the knee. In terms of symptoms, it'll usually be quite gradual. The pain may sort of initially come and go, but then will become more severe. And especially at night, it's important to consider night pain as a red flag. You also might notice swelling around the affected limb. It might even be picked up if there's a fracture related to the osteosarcoma because of weakening in the bone itself. And then these patients also, like we've mentioned, will have a pediatric limp as well. You know, often these patients will be seen initially and may get something like an x-ray, and that usually is enough to pick it up. But then obviously they'll be referred to the orthopedic and oncology team for further workup. These patients might be able to be conservatively managed, but sometimes do need surgery and possibly amputation alongside systemic therapy such as chemotherapy or radiotherapy. This is one of those diagnoses that again can be missed, but in a patient with night pain, significant impact on their day-to-day life, if they've been seen by a few specialists, or if they've attended physio multiple times with a non-resolving pain in their hip, back, or even knee, that this is something you should consider and ensure they've had a plain film x-ray of that area. In terms of taking a history in patients who present with limp, it's going to be identical to the way that you take a history in adults, except that you're going to go through your normal pediatric milestones of birth, feeding, growth development, how they're getting on day to day, what activities they're doing or missing out on. Are they attending school? Are they able to take part in PE or other sports? Are they regressing? And then just your normal adult MSK questions, including pain at the site, stiffness, swelling, and then systemic signs. Thanks for listening.